Uh, Indeed, my plan is to make a presentation on a conceptual framework, because we all are acquainted with the use of technology in medical education, in health, and indeed in the previous session I was seeing extensively presentations are made that how in the primary health care technology is being used. And Dr. Balasubramaniam has already told that how online framework is being used for medical education and for other health workers. If we see, the technology cannot replace a human being either in form of a doctor treating the patient or a teacher providing the training. What the conceptually we basically utilize 5 senses what we are born with, that is hearing, vision, touch, smell and taste. These are the 5 sensory organs we are using through technology, through which either we are getting the information or we are communicating to others. So these are the basic thing in treatment of the patient. For taking the history or even for auscultation, we are using this hearing, which in a technological framework can be recorded and can be used as audio. Similarly, for vision, when we see a patient, we are using the inspection skill with our eye, and which can be recorded and used as a video and utilized through the technology. For palpation or for the touch sensation, recently technology is working that how you can even give a sensation of feeling sitting at a distance. It is yet to crystallize, but surely preliminary research is showing it is encouraging and it is possible to convey the sensation of feeling. Smell and taste, they are important, but they don't have that much of important role either in communication, but obviously in an animal and the lower ear, these play a very important role in communication. Similarly, when we communicate either at an individual level or at a mass level, similarly we utilize for audio system, as I told, either through telephone, radio, mobile. There are many other things. Similarly, in the visual system, for television, for tactile, like visually handicapped, those are blind people, how they communicate? They are basically communicating through their feeling, and that feeling, like braille and other technology which is coming up, which is communicating, even a blind person, he can access the net and he can also update himself and they are learning. Even the blind people now, they are doing PhD and they are doing research. So obviously, these 5 basic sensory organs, they are being manipulated for this technology. Now I will try to link this healthcare and medical education. I am not seeing them in isolation. What I have tried in my presentation, basically what I want to focus, that can we integrate both, because they go side by side. Regarding the primary health care, if I examine a patient as a doctor, what I do basically, I take history, I examine the patient, I do some investigations and I treat the patient. In the history, I ask that what you are having the present problem, your past, family, environment history, all those things. In the examination, again I use 4 skills, that is, as I told you, either inspect or I palpate or I percuss or auscult. In the investigation, similarly, either lab or imaging or invasive. And treatment can be, again, immediately I give some care, I may refer the patient or I will follow up. Can we do all these activities through technology? That is the whole issue. If I can do all these things through technology, then I can redefine the healthcare through technology. That is the whole issue. Now, how I can do that? For history taking, for example, we can digitalize all the records, patient data. Either it is possible in a hospital scenario, it is possible in a community scenario. For example, wherever a community is adopted by a medical college or by in some projects, we can digitalize all the data. Similarly, through video conferencing, I can interact with the patient, I can discuss. Online communication can be there, either I can do chatting, mobile phone, all this technology. So basically the whole idea is to get the history. So all those can be done very well through technology. Regarding examination, obviously, purely on technology, I cannot rely. But surely, the local health personnel, as Dr. Balasubramanian was presenting, that okay, locally one can examine and we can upload the data. We have done in our IGNOU programs, some of the multimedia we have developed, and we have seen that even the health worker at the domiciliary visit, they can record some data and they can upload from there itself. If you link them, they can upload. So the examination data, either it through telemedicine, those can be communicated, or locally we can create a system where one will examine and we can upload the data. Similarly, same thing like examination, investigation also, using the local facility, we can do the investigation and transmit the data, whether it is ECG, whether it is MRI, or whatever. The facility locally available can be utilized. And as far as the treatment is concerned, it is a basically judgment, taking care all the inputs, whatever we have got till now. That judgment can be done by a doctor, either sitting at a distance or wherever he is available, and he can communicate those data. And the data that preliminary, for example, I am a doctor, I am the first contact, this data can be communicated to the other person where I am referring the patient, so that again all these things need not be repeated. Presently that is happening. You go to another doctor, again he will take the history, again he will maintain the record. Can we do a system where all the data can be transferred and those can be saved? Similarly, for follow-up of the patient, after patient gets the treatment and goes, we have no way to follow up the patient. Can we develop a software so that even if he goes back, like in a project mode, in a field setup, in a community scenario, those can be done. So what I am basically postulating, that these are technically possible. Can we do it in a proper way? So if we redefine the healthcare, what we need to do, we have to digitalize all the existing health information. In a community scenario, we can even identify the risk population through GIS mapping. I can find out that in my community or in this village, which are the high risk pregnancy, where the high risk, for example, the cancer patient is there or the blood hypertension patient is there. So those mapping can be done. We can locate their house through the GIS mapping, and all these are being done in a project mode. There are like our IGNOU. In a project mode, they have already demonstrated. They have captured all this data, and it is possible. So if I know that these are the grade 4 malnutrition patients, these are the 4 house, I send my health worker, and I can do the monitoring. So the health worker can be equipped, and he will go to that house, and he can upload the information from the field setting. So the whole monitoring in a groundwork can be done sitting at a distance. Then I will link the referral chain through the telemedicine facility. Now I have mapped the village. I know these are the risk patients. My worker goes and collects the data, and I refer that. The whole data is transmitted, and the doctor can do the further follow-up. We have the surveillance system. Already these are working. Through NICNet, all these things are also working. And the surveillance system can give early indication of the epidemic. And what I want here, that all this system in the periphery is working. But the medical colleges, they are teaching in isolation. Can we utilize this data for our training of the medical undergraduates and postgraduates? So if we can link this, perhaps we can increase the quality in our medical training. And that is the concept on which IGNOU works, and IGNOU feels that we can train any level of provide medical training to the either doctors or to fresh graduates, or even the at a basic training, paramedical training, even after the fresh after 10+2, they can be trained. So coming to the medical education, what I want to emphasize here, there are 3 types of training which we provide. Either it is a field-based training, or it is a basic training, or it is a continuing education or higher level of training. All these 3 will fill into a basic framework or the model that I am talking about, that we can have cognitive domain, that is giving the knowledge part. Then we will have a psychomotor domain. Psychomotor can be divided into 2 parts. The initial part and the reinforcement, which will convert the knowledge into long-term memory. So once it's converted to long-term memory, that will retain. And the another part I want to build, confidence building. If I teach a student in a medical college scenario, and I'll tell, okay, you have learned delivery now, conduct a delivery in a village, can he do? No, he cannot do, because he has not been trained in a resource-constrained environment. So in our teaching model, if we put these components consciously, then our product will be useful for the society. So the model that we talk about, that is distance education institute, or if you are giving online and hands-on training, that is the institute. Then tertiary teaching institution, it is a medical college. Then secondary setup, it is a district hospital or any setup for that region, any where the specialist is available for that area. And the resource constraint, what I mean, small settings, even a private nursing home, a clinic, all these can be for confidence building. So how we can teach? The theory component can be done. Content delivery will be through self-learning material, through audio, video, online, open access. All these can provide us the content delivery. Interactivity can be through face-to-face contact sessions, or with a conferencing, or discussion forums. Even you can do discussion forum online. We can have discussion forum offline also. All those can be done. Assessment, we can have online assignments. We can have continuous and term. We can even utilize the portfolio system for assessment. Quality assurance can be by separating the torment and the internal assessment. Question framing can be at different level of assessment. Accordingly, we can maintain the quality. For the practical component, the content delivery can be in the form of manuals, colored atlas, chart books, all these either in the print or online according to the access to the students. Learning process, it has to be standardized posting plan, because the practical has to be in a hands-on training scenario. We are not planning that only online teaching will be only for hospital administration or for cancer awareness. No. We are planning to give even cardiology training, dialysis management. We are providing HIV medicine training. All these IGNOU is doing because we are having a heavy practical component, and those practical component, it does not require a residential posting. We are trying to, in a modular approach, we are trying to decentralize the practical training. In a different setup, all this training can be in a fractured way can be given and integrated so that the quality is not affected and all the components are given. So this is the plan that we give. We make a standardized posting plan, demonstration, supervision, one-to-one mentoring in a resource-constrained environment, emergency posting. Everything is covered in that. And the confidence building, what we do, minimum number of times a skill has to be practiced. We identify for this skill, it has to be done 10 times minimum, or 20 times, 50 times. This feedback we get from the experts, from the teachers, that they feel okay. So all those we do independent performance. It is not only under supervision, they have to do independent performance. Seminars, presentations, simulation wherever needed, integration with the workshop models. And the assessment will be internal assessment after a group of skills, certificate of proficiency from trainer, separate government examination, linked to the skill development. Now government is planning skill development council. Even we are trying to link with that so that the skill training and independent assessment can be done. And the quality assessment can be, we can have a norm for the institution, we can have teacher-student ratio, we can have logbooks, standardized way, we can have separate torment and the external examiners like the DNB is doing with the OSCE and other things. So evaluation can be independent of the mode of training. That is what we preach. That whatever mode you may learn, but the evaluation will be independent of that. So we don't compromise with the evaluation process. So the design, academic design will be, there can be a group learning mechanism at a tertiary facility, and one-to-one mentoring will be in a secondary facility where expert is available. And we should have an additional, this is very important, additional provision for a slow learner. In a medical college, a cohort of students, they just enter, and some will fail, some will pass. 100% passing is not there, even in the best of the institution, because we don't have a mechanism for slow learners. If we can have an additional mechanism for that, then we can address this issue. So in conclusion, what I want to tell, converting the working environment into learning environment can solve the problem of training large number of health personnel. And linking healthcare with medical education can improve the quality training at an affordable cost. Thank you.